Okay. So hopefully you found that informative. Thank you, Francisco and Andrew, for your talks. So, firstly, we'd like to ask if any of the audience have got any questions relating to the talks, and if you have, if you could come forward to the microphone and introduce yourself. So please don't all rush at once. Any questions from anybody? Please.
Okay, thank you for the very nice speeches. I'm Christine Isaksen from Denmark, and we do this a lot as well. And my question for all of you is, when you get the pathology answer back and it says that it's inclusive or there's not enough material to make a proper diagnosis, how many times should you redo the FNB or FNA? Because we sometimes have to redo it up to 3 times, and then we say that's the end of it, and the patients don't quite like it.
Francisco?
Okay.
You just mentioned that.
Yes, interesting question. That's problem we have had too, but as the rate of insufficient cytological material has been going down, reducing, that possibility is more rare. That what we are doing is just not to repeat it when the appearance of the noodle is benign. We are not repeating.
We often
it's an exception just to this kind of thing when you know how to do it.
We did the thing that we just said, that it's only 3 radiologists who should do the procedure, and it helped enormously. And also we let us guide of the nuclear medicine examination, so we only do the biopsy when we have a nuclear scintigraphy. And we let that guide us, and that has reduced so that we get better diagnosis from the pathology department.
Okay.
Yes, we only do scintigraphy when there is hyperthyroidism, because the nodules, the hot nodules, are not necessary to biopsy, but when there is no hyperthyroidism, we don't do a scintigraphy.
Okay, but it's a complex area, and there is no true answer, I think, even though we heard all of the experts today, but it's still interesting, but I think it's still complex when to do and how to do biopsies.
Well, I think what you said there about limiting the number of operators, as with any interventional procedure that we do, your skill and your success rate is going to improve with your caseload. So the more you do, the better you are going to be at getting sufficient cytological material. As regards your repeat insufficient FNAs, I mean, I agree, and I'm sure we all feel, it has to depend on your, on your index of suspicion, on your ultrasound images. And the reason you get repeated insufficient material from benign-looking nodules is because they're benign. Yeah. It's because they are low cellularity lesions or spongiform nodules. You very, very rarely get repeat insufficient FNA from an indeterminate or suspicious nodule, because those are the nodules with higher cellularity. And so I think it really does need to be correlated. So, as I said, you have a clinical, radiological and cytological correlation. And if your clinical concern is low and your ultrasound findings are benign, then if you continue to try and FNA these low cellularity lesions, you will have more cases of insufficient results. And this may be a role that elastography plays in the future, perhaps, in providing another tier of reassurance in the non-FNA nodule, where you don't have a high index of ultrasound suspicion. So that hopefully we will find out.
I just wanted to make the point as well that I think it's another example of the changing nature of thyroid nodules, moving from clinical really to radiological, because the potential significance of an inadequate or insufficient result from a freehand FNA in previous years is quite different than from an inadequate result from the kind of images that Francisco's shown. If you're using ultrasound guidance and you've made an ultrasound assessment and then you have guided the tip of a needle into a lesion, then if you don't get adequate material out of it, there's growing evidence that the likelihood of that being malignant is extremely low. And that's really quite a different scenario than a freehand blind FNA being performed by a clinician in clinic. So again, I think it's an area where there's a shift in actually what some of these results mean.
Okay. Yep, please come forward.
Just wanted to know something regarding the core needle procedure and what kind of needle you use. What's the instrument that you use for the core needle?
Well, it's an obsession that we have to do core needle biopsy. Yes, the tool we have is the TrueCut 18 gauge, but most of the time in the suspicious nodules we get sufficient material for diagnosis. So it's really an obsession, and I can say I prepared to do it, but we never do it.
I mean, there are a number of papers looking at or documenting core needle biopsy and the techniques. There's a very good radiographics article looking at FNA tips and tricks, and it talks about core needle biopsy. I mean, we do occasionally do it, but certainly for thyroid, lymphoma or anaplastic carcinoma, we end up doing core needle biopsies. And in my experience, if you've seen a Temno needle. So I think the important function of doing a core needle biopsy in the neck is that you don't have an automatically propelling needle. The Temno biopsy needle allows you to have perfect control. You can biopsy things behind or adjacent to the carotid or the internal jugular vein. If you are in plane, you can see, you push the gate out, you can see the gate coming out, facing the ultrasound beam, you know exactly where you are. It is a safe method of investigation, and the Temno needle is excellent.
Is it similar to the Cook needle which you use? We use the Cook coaxials. Is it similar to that?
I don't ever use a coaxial system in the neck.
No, we don't use. You take out the coaxial and just do the needle. Is it similar to that? Because
I don't know the Cook needle. Temno is a generic make that a number of companies make, where you push the needle forwards for the 1 or 2 centimetre throw, depending on how much you're taking. Some core biopsy needles you can choose a 1 or 2 centimetre throw, but the importance is that you control the needle going out into the lesion. It doesn't jump out automatically when you fire. And I think that's the most important thing in the neck.
Thank you very much. The other question I just wanted to ask regarding elastography is, we used elastography, the qualitative approach. We find RFE is a little better. For breast, we found this one better. So I just wanted to also reaffirm with you your experience. And really whether you find the numerical value of use or just the grayscale imaging for RFE.
No, it's a good point, and it highlights with the elastography that there's such variation both in the technique that actually you're using to demonstrate the elasticity of the lesion and the numbers or the method that you're then going to use to make that assessment. In our study, we performed a subjective assessment, and really what we were trying to do was say, could we just bolt this on to our B-mode ultrasound in the way that you would colour Doppler or any other button on the machine and make a subjective assessment? I think the potential strengths of that are that it's quick. I think if you are an expert operator and you're doing high volumes of that, using that technique, there's some good evidence that that's going to be an accurate method. But yes, the problems are the variation between different observers. We've seen with thyroid nodules how important it is to make an assessment, to have that documented and be visible to others. The problem with the subjective assessment is that it doesn't easily sit and it's open to question. So RFE with Siemens is one example of how you can use shear wave elastography and make a quantifiable measurement. And of course, the attraction of something that's quantifiable, if that's reproducible between different centres, between different operators, then we've got the potential to use cut-off levels. We could potentially see that in the future in guidelines of knowing that a number that's not subject to any other variables, but a number that can be used and with a sort of negative predictive value attached to it. I think whatever the future is going to hold with the elastography in the thyroid, if it's going to be useful, yes, by whatever technology, it needs to become more standardized. There's no doubt about that.
Thank you. Thank you very much.
Hello, my name is Kunwar Bhatia from Chinese University of Hong Kong. Some very nice talks, thank you. This is just a point or a question for Andrew McQueen. You gave a very nice talk, and it seems quite optimistic. And some people's experience has been actually quite varied and perhaps less optimistic. In fact, one of the largest studies published, I think in radiology, with something like 900 or 700 plus nodules, gave some very poor results for strain elastography. And my personal experience is that it's very operator dependent. And perhaps you're intimating at that too. And strain elastography is a very operator-dependent technique because you have to apply compression. And it's believed that shear wave elastography may be less operator-dependent because it gives a quantitative metric. However, we've just done some recent work, and that's shown that even the quantitative metric you obtain from shear wave elastography is operator-dependent. You can vary the amount of compression you apply on the thyroid gland and alter the stiffness of a nodule, and we've produced a poster which you can see on ECR. I just want to raise that point because I think operator dependence is a big issue about elastography that needs to be addressed. And so asking you a question now, in your experience of performing strain elastography, it seems you were publishing, how easy was it to perform? What was the learning curve like? How observer consistent or how operator dependent was it in your hands?
Okay. Yeah, I mean, I think, Kunwar, you make a lot of very good points, and there's some of the weaknesses that I touched upon really in the talk, but are there both in your article and out in the literature of the problems people have found with the technique. I think you're quite with strain elastography, because you are manually compressing, because the degree of compression that and force that you put in is going to alter the image. Yes, there is a learning curve. In our institute, there were 3 different operators who were doing a high volume. There's one in particular who's done far more than anybody else. And there's no doubt that your view of elastography changes as you increase your experience. It's not a case that you're simply passively observing. You are actually actively producing the image. So I can't really put a specific number on the number of cases, but there's no doubt that from the start, through as you build your experience, that interaction is going to change. I think one of the key bits, I would say, where I see the potential value with elastography is actually identifying its role and its niche, and that really means identifying what is the clinical question you're trying to answer, what's the nodule type that you're going after. We showed with any cystic areas, calcification, major limitations really with strain elastography, less so with shear wave, particularly cystic, as you say. But ultimately, if you've already seen a nodule which you've decided you're going to FNA on B mode criteria, elastography is not going to change anything. Similarly, if you're looking at a spongiform nodule, you've got no reason to be looking with elastography unless there's a very high clinical risk and concern. So I think if we can start to look at the test with a far more narrow number of nodules, and I would suggest it's really the solid kind of isoechoic or hyperechoic indeterminate nodules, those where we believe there's a low likelihood of malignancy, and we're looking for reasons not to FNA, to try and leave them alone. I think if our experience would suggest, and similar to others, that reproducibly very high negative predictive value of a soft assessment. There may be limits in how that assessment's been made, but between different studies using different criteria, the soft finding consistently has a very high negative predictive value. And I think that's potentially useful if it means that we can take some of these indeterminate nodules where we're embarking on a process of patients having FNA, an invasive procedure, then having the fact that the cytology result is not binary, it's not going to be benign or malignant, it's a spectrum as we've seen, and potential patients having unnecessary surgery and a lot of patients having unnecessary anxiety. I think if we can improve our negative predictor value right at the start so we leave some of those lesions alone, I think that's an important specific role for elastography.
Thank you.
Right. Okay. So I'd just like to thank once again Andrew McQueen and Francisco Campoy for their talks today, and I hope you enjoyed the session. Thank you.